We're joined by Dina Velocci, President-elect of the AANA, Dr. Timothy Dowd, Special Project Manager at Somnia, and Stephen Burgess, Director at Ancore Health. My name is Megan O'Mara, and I'm the Director of National Recruitment with Somnia Anesthesia. And today we are going to be discussing the 2020 Anesthesia Labor Market Survey and the findings. So thank you so much, guys, for joining us and for being here today.
My pleasure.
Good to be here.
Great to be here.
Thank you. Before we dive into the survey's findings, I was hoping each of you could just share some high-level thoughts on some of the unfathomable events that we have encountered in 2020 and the impact that you're anticipating on healthcare, not only the healthcare industry, but healthcare recruiting. Dina, do you want to get started?
Sure, thank you. No question, as everybody will say, that 2020 was an unprecedented, unexpected year. I think it caught not only providers, but as well as the healthcare industry off guard of something that came so fast and furious. And, you know, I think this has been the first time probably since H1N1 that we had to deal on something on a mass level. You know, H1N1, we know it was there, but it was more containable. This was something that really swept the entire world. And we didn't know much about it. We didn't know really how to treat it. We had an idea, but not really. And so a lot of it caught us not only on a supply demand for how to move healthcare providers to the hot spots, but also we needed the equipment, the PPE, and then the protocols and how that was all in place. So we really didn't have a very good emergency management preparation on something on a very large scale pandemic level. And I think there was a lot of take home points and a lot of learning points that came out forward from that. As far as recruitment, as CRNAs, I can speak on that level. What we've not seen a drop in our admissions to our schools and our applications. You know, we talk about there's a workforce shortage, but for us, we are definitely seeing still the same rates of, you know, 2 to 3 per spot application. So for us, we are fortunate we're not dipping in that aspect for us, but yet the volume of what is needed, the demand of the market, the shifting out of hospitals to ASCs, coming out of the OR, the increase in number of places that we're now going outside the traditional OR of anesthesia, that demand is impacted every provider. And so how do we meet that need is really the question. That's kind of my 2 cents. Thank you.
Dr. Dowd or Stephen, anything else that you'd like to add?
I think this brought up a really important aspect to anesthesia, that is the COVID crisis. And that is the other skills that the anesthesia providers were able to bring to the table so that they were smoothly able to kind of move out of the operating room and into the ICU, both the physicians and the nurse anesthetists, to provide care for very sick patients. They showed a great deal of cooperation in building teams to do intubations under very difficult circumstances and very uncomfortable equipment, because that's what was required for safety. And so I think it really highlighted and enhanced what was already a pretty good cooperative working environment. And I think that goodwill you know, tends to reverberate into the future and is likely to have an effect on recruitment, a positive effect on recruitment going forward.
Absolutely. And I think the one thing I would add here is what it's accelerated both from an emotional standpoint and what's coming out of it is the shift of where we've broken barriers that have historically existed, both in what people ask for. You know, when you come out of a year of being in the trenches, people then begin balancing out, you know, and I know the survey really talked about work-life balance and others, but what we're seeing now is people are being more selective of where they want to go and where they want to move, which completely changes some of the historical trends of supply and demand, as well as what people are recruiting on. At the same time, as Megan, as you mentioned, the shift between inpatient to outpatient to ASC has changed even the economics of what people need, all compounded by a lot of institutions use survey data to do that. And no one knows what that's going to look like. So how do you then begin in recruitment balancing what is best for the system, the patient, and the providers, what they want for the and need for their families through that? And I think it's pushing the conversation probably faster than it has ever been to find the right balance. What that right balance is still up in the air, but I think I'm excited to see how that is more well-rounded than it may have historically been.
Absolutely, Stephen. So the survey included demographic information from both the ASA and the ANA, and it reports that 64% of anesthesiologists are male, while 60% of CRNAs are female. The average age of anesthesiologists is approximately 46, and for CRNAs, it's about 38. Do you have any thoughts about this?
Mine is, I'm not sure we should allow children to be giving anesthesia, but other than that, I think it's interesting because I think that the medical schools are now about 50-50 in terms of their gender distribution. So whether or not that's going to make a change to sort of what the anesthesiologist community looks like in the future. I still think that the nursing schools are predominantly female, and so that's the that's the source for the CRNAs. So that's likely to remain a female-dominated specialty. But I think that the anesthesiologists will move more toward the CRNA distribution of people.
So historically for us, actually, we were more towards a 50-50. Our profession for a long time, a lot of men went into it. They went into nursing, but didn't want to do the bedside nursing, and they wanted something more. So they went into anesthesia. And now we're seeing that shift where you see more women actually coming into that. And I think it's because, one, for the longest time, we were known as the best kept secret, as a profession. And because of our advocacy and getting out there, explaining who we are, what we are, and getting that exposure, I think more bedside nursing, ICU nurses are seeing there's an avenue to get away from the bedside. I think where we see the shortage at the bedside nursing, because it's tough. The acuity has gotten a lot more. The demands on the nurses are more. There's less remuneration and compensation for them. And the hours, it's taken a toll. So they're starting to look at that work-life balance and say, do I really want to spend 25, 30 years at the bedside like that? And in ICU, it's rough. So they see anesthesia as like, you know what, I'm going to, work smarter, not harder. And so they go to anesthesia school, they go to nurse practitioner school, or they find the next level of iteration up in their profession. And that's why we're seeing, we haven't seen the dip in numbers coming to our schools. And so we're seeing that change. I think we'll be more 50-50. What I see a big shift for us is actually in diversity. We are getting more and more diverse populations. For the most part, nurse anesthetists are about upper into 98, 99% white. What we're seeing now is a big shift coming with a lot of Latinos, Blacks, Asians that are coming into our programs. And a lot of it is to our credit is a couple of our members are strong advocates of going back into the urban areas and recruiting them in, because basically, just like the rural area, you're going to get a provider to go back to live in the rural area because that's their home. Same thing in urban areas, you're going to get people to go back into those urban areas. So that heavy recruitment has really starting to shift our profession, and we're starting to see those numbers increase. So we're getting more, what I say, more like the population. If you pull the numbers, from a population down into our profession, you're starting to see that show. So that's where we're seeing our shifts in our profession going forward.
The survey then goes on to ask about licensure and geographic practice preferences. More than half of all respondents were licensed in multiple states. And at the top 4 practice states for both groups, both anesthesiologists and nurse anesthetists, were California, Texas, Florida, and New York. What are your thoughts about that correlation?
Can I ask a question? When you asked that question, were you asking licensure or where they worked?
So that was top licensure.
Okay. Mm-hmm. I think those numbers are skewed, and I'll give you an example why. I'm licensed in New York, Michigan, Florida, and Tennessee. I primarily work in Michigan and then New York. I've not worked in Florida. I just carry that license because I do live here. and I travel around the country to work. So those numbers, if you're asking me how many licenses I hold, it may skew, and a lot of CRNAs have shifted to that independent 1099 work, out of working the W-2s because just because they want the flexibility in their schedule, they want to travel a little bit, and they rather manage their own benefits because the benefits have dwindled in the W-2 realm, and they're finding that they can actually, they'd rather get more money and then figure out how to manage their money that way. So with that, you're seeing more and more of our population shifting to 1099. So I'm not so, like, those areas are important. Like Florida's a big, always a use place to go. New York is paying well, Texas, but I think I don't know how exact those numbers would be if you ask the question on where do you primarily work, what state you primarily work in.
They are the 4 largest states in terms of population as well. So it's not unusual that they would have the most providers because they have the most users.
For us, though, we have 7 states that are large states. And so that leaves out Florida, Pennsylvania. Those states actually have more providers than actually the other states. So, again, I just see our population and how many people have shifted all over the place and they flip, which I agree. The population is bigger in New York, obviously, California, Florida, but we do have some other states that have significant amount of registered CRNAs in those states, but yet they just travel or they live on the borders and cross back and forth is what we do see a lot happening for us, at least.
So Dina, I think going back to that, my question to you would be, is that a significant, would you call it, hey, that's just a small trend pushed by COVID, the time to be wanting much more mobile in that, which then kind of pushes in the recruitment in the long term. If people are innately desired to be mobile, does retention then become a conversation piece of, as people are looking, are they looking more for loyalty or, a newer generation wanting to travel the country in a more dynamic 2-year block? I'd love to know your thoughts on that.
That's a fabulous question, because what we have missed the conversation is, what about generational changes, right? Our older generation population like to stay still. If you look at your, what I call the digital darlings or the, iGens, they like to travel. They're not tied. That whole loyalty thing is really not about that. It's about work-life balance and what they're getting out of life and where they work. So for them, our younger group that's coming up, for them to find that value of where to work is really more towards, they want to live in the cities that they may have fun, or with the push of COVID, what we're seeing, even if you look across industry, is people are leaving the big cities and are looking more going to the rural areas. That's why you see the big migration coming out of New York City, and they're going out into the rural areas. You're seeing the migrations out of Chicago. You're seeing them all moving into Florida. The days now, all the rural areas, everything's getting snapped up in a lot of the rural areas because people now can work from wherever. That shift of having to be in a brick and mortar building changed, not so much for us, but that whole mentality, if their spouse is doing it, you're going to see that CRNA shift as well into the more rural area as well. You'll see that even more. And tie that into, in the rural areas, we see more of an increased use of our scope of practice. They can practice at their top of their level. They can have more, there's more autonomy. There's a lot more independent CRNA only sites. So that is another piece of attractiveness that maybe they never would have thought of before, but now are starting to take a look at that as something that's enticing. And you can see that in the trend, I think further down in the survey, it showed that you saw CRNAs now looking more towards independent practice and more increase of scope of practice. So it kind of aligns, and we're starting to see that shift that way. So
what do you think? What do you think the impact is going to be on the quality of service delivered to the hospital when the workforce becomes very mobile? And so there's a lot of turnover of staff, folks not kind of loyal to the area, loyal to the hospital. The traditional, consistency of the anesthesia team, and I don't mean a team model, I mean the people that are actually delivering anesthesia, is different, because what you're describing amongst the anesthetists is also true, maybe to a slightly lesser extent among the anesthesiologists, but only slightly lesser. If you're a hospital administrator, I've done that job too, you become concerned about that. What do you think the impact will be?
So generally, and I can give generalities and speak for as a practitioner, when I used to work in a stable place, you become more comfortable with, trying different things. What you find is that when you start to travel, you actually enter a facility and you tend to make more conservative judgments on what you're doing until you can get the lay of the land. That's what you see. Majority of the providers that I work in a group of people that travel around, you go into a facility and it's kind of like, okay, you get your basics and your bearings, but you're very cognizant of the decisions you make. And, you can do anesthesia in many different ways, but then you tend to be more cautious and take more of a very conservative approach of how you provide anesthesia until you get an understanding of the facility and the culture. And that is what you see a lot of people that do 1099 work. Now, the first one stepping into it, you have to learn. That's a learning curve. But as you do it over time, as a very seasoned 1099 worker that flies all over, you have a different style of way you approach things. So, my thing is I come in, I take a look at, the staff who's there. I ask about the surgeon's skill set, the staff will tell you. And then you kind of assess the people that are around you. How do they conduct themselves? Are they doing a full on assessment and talking to the patient and taking out the stethoscope, or are they not? Those little cues kind of tell you the lay of what's going on inside the hospital. And then it's up to the provider to make that decision of, how strict you want to be careful with that. And if you look at the rates, this has been going on for a very long time. So if you look at our actuarial rates, I can speak for CRNAs, it's gone down. So if we were potentially having these issues, you would see those rates bump up. You would see the increase in malpractice, and we're not seeing that. It's not showing out in those numbers. So being that we've done it consistently and it's increased, we haven't seen the bump in numbers on our malpractice rates and our actuarial rates. That's actually kind of decreased, either stayed stable or come down a little bit. So to me, that first blush of information will give you a good key KPI on that would be telling you that it's really not shifting or impacting it as much, but it can always change. It's something to watch.
And it's not a real controlled experiment. There's certainly there continue to be enhanced technologies that make it safer to give anesthesia. I would see it more as a challenge of getting efficiency in the operating room, that teamwork kind of structure that operating rooms have traditionally developed. It's harder to develop if the team is constantly shifting.
I agree with you on some aspects, but I have walked into some places that to say that roller skates is a mild thing. I mean, I've watched that we've had literally 5 to 10 minute turnovers, and if you don't keep up, they're on to you and they're not going to keep you there. They're going to bump you out because they're not going to flow their system. So it's a kind of, it depends on the facility and the culture. If they're really if the culture's set up from the hospital that they want turnover and the turnover is going to be this, and you can't match up to it, immediately the staff is going to say, this person's got to go because they're holding us up. So really a lot of it comes down to the culture that you walk into. I've walked into some facilities, it's not an issue, and I'm the one kind of pushing, like, come on. And then I've been in some facilities that I'm like, I better get there early. I better set up because I got skates on because we're going to do 15 cases before 1 o'clock, and I'm going to be moving. So, and that's doing orthopedics and we're flipping rooms. It's crazy, but they've got some places that are that streamlined that if you step in, you got to be ready to handle that. And they interview you and ask you if you can handle that. So I've seen it both ways, which to your point, but I've also seen it the other way, that if you don't measure up, you don't work there. They find somebody else.
The survey also reports that the percentage of anesthesiologists earning more than $500,000 increased from approximately 20% in 2018 to 25% in 2020. For CRNAs, the percentage of those earning more than $300,000 nearly doubled from approximately 6% to 11% in 2020. What are your thoughts on those salary trends and how will they impact future hiring?
So, I mean, I have an interesting take on this. Again, it's not as going to be the clinical side, but if you look at how a lot of times kind of have to bifurcate this in two ways. One is those doing it purchasing within the systems, academic institutions versus independent or for-profit groups. A lot of the health systems tie it to survey data, which we all know just increases. That is not innately bad by any stretch of the imagination, but it is something that should be, and where I alluded to earlier, should become more of a guidelines of how do we define this and matching the economics. Because where this conversation we just spent the last 10 minutes talking about is groups coming in and out, how do we then price and create job openings that allow for transitions in and out? But I think the reaction has, at least in the last year to two, has been to increase salaries to make it so sticky that no one wants to leave. Well, then you got to ask, are you creating the right culture for what you want? So if it's a generational change, well, that's all layered in with survey data pushing us up and up and up. COVID then coming in and creating a weird supply and demand issue over the last year. And then Dina, as your point, people wanting to move to different places. The issue is it's not just rural versus urban, it's a shift from East Coast to West Coast. I'm based here in Nashville, where the economics of those moving from Seattle, Chicago, New York into little Nashville is wildly different. And I think the pushing up of that survey data is, one, a shift to the importance of these roles and the uses of CRNAs and anesthesiologists outside of the inpatient setting, as well as more PE, VC money steps into the ambulatory care surgery center and say, I can't afford to be down a person. So you get all of these forces pushing, but hopefully on the back end of COVID, we start saying, okay, what's economically viable for the people we're recruiting into these positions? Because at some point, pushing up to 500 and 300,000 may be the right answer for some, but are you going to get the right cultural fit? Tim, to your point, to keep that continuity of care going up. I think it'll still continue to rise for a while, but we're already seeing some for-profit groups absorbing groups, bringing these things in-house. And we know that larger for-profit are going to push this down and start creating stickiness that we're seeing in other parts of our economy. Benefits, work-life balance, creating a stickiness that isn't dollar-driven in the first way, but how do we create a culture that you want to be a part of? Then the dollar amount, yes, still is going to climb, but it's going to be paced with retention. Are these people in the right place? If they're happy, they're going to stay. Versus what's the higher dollar amount that we can push these up with?
So
I think it's very complicated. I think there's a lot of reasons that you choose to take a job or where you choose to live. But I think what Dina is talking about when she's talking about mobility is it has created a marketplace which is not regional. You can be living in Florida and working in California, and the Florida hospital now has to figure out a way to compete with the California hospital, which might be willing to pay more. Now, their strategy has to be either we pay more or we make it so much nicer to work here and so much more convenient that our staff isn't going to leave. There remains on top of this, I mean, the classic economic, if you have a shortage of anything, it tends to become more expensive. Rather than worried about whether it's private equity or whether it's national anesthesia companies or local hospitals, it's probably the principal governor on this is the federal government, where the federal government is constantly trying to push down on the increase in cost, and that has to be reflected somewhat in professional salaries. So it's a highly complicated analysis and very difficult, and I've always said, if you want to plan out 5 years in medicine, just think about what happened in 2020. That's God laughing at your plans. So this is who knows what's going to happen in 5 years, but there remains a shortage of anesthesia providers, and where there's a shortage, there is a drive to make them better compensated.
So let me add another little layer onto all of you guys. When we talk about, you brought up teaching hospitals, what we refer to as the golden handcuffs. And what most people don't understand is that some of these major institutions like Vanderbilt, Duke provide tuition assistance, college tuition assistance up to 70%, 50%. So CRNAs will go work in these institutions until their children are through college because they get that as a benefit. So for some families, you have, like Vanderbilt does, it used to be most of the CRNAs were 70%. I think they dropped it now to 50%, but they do up to 3 children. Well, most people have 2 kids. So it would behoove that partner to stay at that institution, even though they can drive a lower, and they do have a lower, salary for the CRNAs there, and it's limited scope of practice per se, because it's a very controlled environment. They'll stay there because the benefit of getting their college tuition paid for their children, they work the numbers, right? It just depends. So that's a unique piece of that, why you can get that glitch. Or I used to live in Nashville. So Nashville, yes, is the hotbed, and everybody in their family wants to move there. So a lot of people will make that change because their desire to live there is more important than work-life balance or whatever, or money or scope of practice in their job. But the big thing that the big elephant in the room is our actual reimbursement. And that's the price transparency that's coming down, the bundle payments that are coming down. You're looking at Optum, that has become the behemoth in the healthcare industry with data. Everybody's going to them, everybody's using them with their data analysis. And from there, that is really controlling. It's the insurance companies, the private insurance companies, that are really pushing that battle between the providers and providing healthcare and the hospitals. And I think COVID definitely accentuated it, sped it up. I think when you look at telehealth medicine, you saw a huge change where it used to be problems with barriers in intercommerce. They hadn't worked that out. All of a sudden COVID came, and also now we can figure out how to do telehealth and bill for it, and before we had all these issues. So it's interesting, the dynamic changes that are going on in healthcare on a insurance level and a CMS level, and then where we as anesthesia is going to fall out. And there's this great quote that said that, anesthesia was born the handmaiden of surgery and will forever be the slave of it, because nobody's going to a hospital saying, who wants to have anesthesia today? It's always, we're service. So as long as the surgeon's there, you're going to battle the surgeon for the fee, and you're going to battle the hospital for the fee. And where it's very hard for us, whether you're CRNA or anesthesiologist, we're going to have to come together and find that way of making sure we are going to stay getting that reimbursement, because otherwise these salaries will tap out. You can't continue to afford these salaries, especially with you're seeing the actual going away of subsidies and all that stuff, because the reality is COVID broke a lot of hospitals. And so they're looking at it and saying, well, this is kind of unsustainable, how we're going to do it. And then you've got the crunch of, you've got these salaries going up. There's going to be a mark off somewhere. Where is it going to go? I don't think we really don't know. But this is kind of where I see the headwinds going currently today.
Dina, you summed up my next question, which was, where exactly do you see the future of anesthesia? Dr. Dowd, do you have any thoughts on that as well? That's perfect.
I think that COVID really said anesthesia is going to be in a lot of places. I'm critical care boarded, but I was working primarily as an anesthesiologist and was seconded basically to a hospital where all the critical care staff got sick. That is the physicians and nurse practitioners in the ICU got sick. So they brought me in to organize the ICU response for the hospital. And I was backed up by both physicians and nurse anesthetists who weren't even local. I had a group of really talented CRNAs who came up from Virginia. I was in the New York metropolitan area during the spring of 2020, and they were wonderful. We worked, we had a wonderful team environment, and it was a bit of a MASH unit because we were very busy. It was emotionally very draining. The protective equipment that we wore was very uncomfortable. But it was rewarding in that we took care of of patients and really did the right thing. And I think it was great in that respect. I think that will push anesthesia back into ICUs where they've sort of gotten out of for a little bit. The shortage in the operating room had sort of sucked the critical care doctors out of the ICUs. Now they're, hospitals are looking for that critical care aspect of anesthesia. Pain continues to be a big chunk of where anesthesia providers go. It isn't just out of ORs, to ambulatory surgery centers. It's out of ORs and into what I think the ASA calls NORA and, what I like to call ectopic anesthesia areas, areas where they're not traditional delivery points for anesthesia, but there's a lot of surgery that's not surgery anymore. They're done in radiology suites and interventional radiology suites where the patients are still as sick as they were in the OR and the potential risks are still great, but the results after the procedure in terms of the complications is much lower. And so it's something, places where they want to go, the cardiac cath labs. There's all kinds of places. I'm a pediatric anesthesiologist, and there's a lot of MRIs that we do under general anesthesia because we're sort of dealing with babies. So I think the direction of anesthesia is to be spread out from the operating room. So certainly from the traditional operating room, it's been going on and it's going to continue to go on. In fact, it's going to accelerate because the technology is going to allow things to be done in non-traditional ORs that could have been done in the OR, but were done much more destructively. Every surgery, you have to cut somebody open and get them on the inside. And when all you were trying to do was repair something on the inside. So you were doing damage to get to the place where you were going to deal with it on the inside. And so these things of being able to sort of work from the inside out, laparoscopic surgery was the beginning of that. But the radiologic interventions that the cardiologists and the radiologists can do now are just amazing. And but they still require anesthesia. So I think that's where it's going to. It's the spreading oak tree. We're headed out of the operating room.
I think thinking about this year and all of the events really leaves us speechless, right? And I think that when we gather next year to review our 2021 data, we're going to feel this impact, well beyond these years. I can definitely speak on behalf of Somnia and say we are so grateful and thankful for all of our frontline healthcare workers. And this will be very interesting to see the lasting impact on healthcare. You can access all of our resources on somniainc.com for any future guest talk, any survey results, labor market survey, everything is available. We truly appreciate everyone's time on the panel this afternoon. Thank you so much, and enjoy the rest of your day. Thank you.
Thank you. Have a great day.
Dina.
Thank you very much, everybody.